Hey fam, how's it going? It's May already, and I'm excited because that means the end of the school year is upon us. We have summer break coming up. I mean, all the things. But what I'm even more excited about, fam, is talking about a broad spectrum of sensory processing and how it affects our warriors. I'm Nicole Morris, licensed marriage and family therapist and mental health correspondent. And let me be the first to say, welcome to the family. The OCD family, that is. I am here to create a community of support for family members, spouses, partners, parents, adult children, as there may be adult words, and chosen family of OCD sufferers and their community. I've had over 22 years of experience in the mental health field, but please note that this information does not qualify or substitute as a diagnostic evaluation, therapy, or treatment, and it is presented on an as-is basis. Please follow up with a qualified mental health provider in your area regarding concerns for yourself or loved ones. Thank you for joining us today. Now, let's get started. Alrighty, Rooney. Such a weird phrase, but oh well. I said what I said. So, fam, yes, today we are talking about all things sensory, and I'm super excited about today's chat because this panel has been a dream in the making, I kid you not, for almost a year now. But you know what's even more exciting? As May leads me towards wrapping up this season's long-form content for the return of our water cooler chats, which is my summer series that drops in short-form quenchers, I'm really fortunate to be bringing on the panels this month. So today we have part 1 of 2 meet and greets with my sensory pals. And also coming up in May, we have a dynamic Q&A to discuss your questions and further follow-up for our PANS, PANDAS, and Lyme disease warriors. Additionally, I'm planning a really special Memorial Day episode with Dr. Elizabeth Maisel to discuss and honor our military service folks as we move into a time of remembrance for military members, vets, and family members that have paid the ultimate sacrifice. So I'm really honored to launch into May with these amazing colleagues. And for part 1 of our sensory panel today, I even came up with a little joke. Because are we even family if we're not making mom and dad jokes? I mean, come on, right? So why did the tongue get upset when it was hanging with the other senses? Because, fam, it wasn't given a tasteful introduction. I'm telling you, if this podcast gig does not work out, I might have a future in therapy jokes. Granted, a very niche audience, but there you go. I will say, though, you know who will get and deserves the best of the best introductions here, fam, are my esteemed panelists. Because they are such an amazing bunch of caring and compassionate professionals here to extend hope to our OCD and OC-Related Disorder, also known as OCRD, warriors. So let me get right to it, because we have a lot to discuss, and I bet you'll be at least as fascinated as me to learn along with us. So first up is Dr. Briana Pollard, OTD, our occupational therapy expert. Briana has over 20 years of experience as a pediatric occupational therapist in Southern California, and her area of expertise includes sensory processing disorders, pediatric feedings, and so much more, y'all. She's also super passionate about improving health practices to better meet patient and family needs, and is currently working at Children's Hospital Los Angeles, also known as CHLA, where she not only provides outstanding patient care, but is also involved with several research studies and is really quite the unicorn because I have to tell you, fam, she consults with the University of Southern California, USC, which also happens to be, I know for a fact, her alma mater, and she guest lectures there from time to time. But she also, in addition to that, teaches for UCLA's fellowship program, and for non-locals, the Trojans and the Bruins do not play nice. So it's no wonder that Briana is such a whiz at helping families with conflicting sensory systems make fetch happen, because she is already balancing the USC-UCLA rivalry, and she's doing it beautifully. Briana, you knew I had to have a little fun with you there, but I am here for that. Also, we have Amber Young, LMHC, our autistic OCD expert, joining us today. And she also specializes in effective treatments for OCD, anxiety and related disorders, and trauma. Amber is a late diagnosed autistic person who is passionate about advocacy and the amplification of autistic voices and needs. And I can tell you, fam, that I have had the pleasure of consulting with Amber for some time now. I can't even remember how long, honestly. She is a fellow Hoosier therapist, a wellspring of knowledge, and a treasured resource. Next, we have Dr. Lisa Conway, Ph.D., our BFRB expert, who is board certified in behavioral and cognitive psychology and is also in solo practice at Exposure Therapy Chicago. She specializes in using evidence based practices to help clients with sticky minds, particularly those struggling with body focused repetitive behaviors, also known as BFRB. Ah, see, the expert, BFRB expert, as well as anxiety, OCD, and trauma. She's actively involved in OCD Midwest, and she's a member of the TLC Foundation, the International OCD Foundation, and the Association for Contextual and Behavioral Science. And this isn't my first time pairing up with her, as you will hear more about a little later in the show, so we are super thankful to have her joining us in today's conversation. And lastly, we have Dr. Max Maisel, Ph.D., our Tic, Tourette syndrome, and even just right Tourettic OCD expert. And that's quite the specialty there, fam. I've already let Max know I think he wins on location, although I like all of our locations. But I think he wins because he has a boutique group practice in Redondo Beach that specializes in helping children, teens, and adults overcome anxiety, OCD, and OCRD concerns such as tics and Tourette syndrome and body-focused repetitive behaviors. Max is passionate about tailoring evidence-based interventions to fit the unique need of his clients, including acceptance and commitment therapy, otherwise known as ACT, exposure and response prevention, which this fam knows as ERP, metacognitive therapy, and CBIT, which Max is going to tell us more about in just a few moments. Max has worked in outpatient, intensive outpatient, and residential levels of care, and he's currently the president-elect for the Southern California chapter of the Association for Contextual Behavioral Science, or ACBS, which Max, I didn't realize that. Congratulations, Mr. President-elect. That's very, very cool. So as you can hear, fam, we have a crazy amount of talent and knowledge across our panelists today. And for many, they treat and wear many hats. But for the purposes of today, we're going to focus in on the highlighted scopes to hopefully help you, family, understand about each of these treatment perspectives in a unique and individualized way. So while certainly there is a lot of overlap, we also want to recognize where and when perhaps some of the struggles we're encountering in our loved ones or our family systems may be pinging in one or more of these given areas. But as we'll discuss more broadly, we're all sensory beings. So today's chat is intended to lay a foundation and understanding regarding what each of these scopes entails, what and when treatment is appropriate, and more. And then next week, we'll be able to put this foundation to the test, fam, as we explore more of the multifaceted questions and concerns that can show up across these different scopes. So one last little housekeeping note, and we'll get to it. All the info on our great guests and resources that come up across our time together will always be available to you at this episode's blog over at ocdfamilypodcast.com. So if you want to learn more about any of these dynamic sensory beings, don't forget to check out their details and more. Also, particularly for our newer fam joining us, if you hear a lot of letters or acronyms during our time together, trust me, we will always try our best to break down what we're talking about along the way. And there may also be some new words for some of you. But if you're anything like me, which total nerd alert, and hey, I'm not ashamed, I really enjoy learning new words. So we'll use terms like allistic quite a few times throughout this episode, which is used synonymously to language like neurotypical or neuronormative, but is less prejudicial or pejorative to the autistic experience. And my aim isn't about any sort of correctness as much as it is an aim to be affirming and inclusive, fam. So I'm learning, and I am always open to learning more. Because we're fam. We keep it real, and we take care of each other. Also, Lisa, your lexicon is next level, and it kind of makes me want to play words with friends with you. So if that's still a thing, maybe we can make that work. But for now, fam, let's just dive into all things sensory. All right, well, welcome back to the OCD Family Podcast, and I am just so pleased to be with this amazing dream panel. I've told them many times today, and I am just so grateful for all of you and your time. You have been so generous in coming together, and ultimately, fam, I am hopeful that this chat not only can maybe teach you about some different ways that sensory processing can show up across the board, just for people in general, but also how that can tie into different treatment presentations, different mental health presentations, physical health, and all the hope that there is available. So we have a panel of just amazing experts in with us today that are going to be sharing a bit about what they do and their expertise. And then they're also going to talk a little bit just here at the start before we springboard into such interesting discussion about how sensory processing really impacts their field of practice and the wonderful people they work with in their lives. And so we're going to start off with what is more familiar across the board in terms of sensory. When we think of a professional, we may think of an occupational therapist. I know before I was in my 20s, I didn't know much about occupational therapy. And so I'm going to go ahead and start with you, Briana, if you can tell a little bit about yourself and what an OT does.
Yes, thank you, Nicole. And thank you so much for having me a part of the family here. It's very exciting to be a participant. So, in occupational therapy, for those who may not be as familiar, you may be working with an occupational therapy throughout different parts of your lifespan. We can also be found working in the school district or working in early intervention with the 0 to 3 population. We could be seen in hospitals, in rehab facilities, or even on job sites if you're looking at ergonomics. So OT kind of does a whole gambit of different things. And we like to think of ourselves as very much a holistic profession where we look at the body, the harsh sciences of the body, but we also dive deep into psychology and kind of blend the two together. So when we're looking at sensory processing, which often a lot of OTs do specialize in sensory processing, we're looking at how the body responds to the input inside the body, as well as the environmental stimulation in the environment and how they respond to it. So they may address these sensory processing difficulties through different exposures. But often what you see is if we have a client come in that's having a hard time tolerating certain tactile input, we may be pairing it and not just working on touching different tactile stimuli, but actually pairing it with a counter sensory stimuli to help decrease the icky feeling that may happen when you touched or you're getting exposed to different tactile input. And that input that we often pair it with is called proprioceptive input. When you're working with children, we also look in the context of the whole family, right? Because everybody has a central nervous system and we all respond to different stimuli. We are all just sensory beings. And so we want to look at not only a child's sensory system, but also look at the mother, the sister, the brother, the father, anybody who may be working with this child, because they're all going to play off of each other and they need to understand each other's sensory systems as a whole. So that's a little bit of how OT may look at it. But just like every person, I really believe you need to have a team. And so OT should be working with your whole team and not just only in its own silo. So I feel like OT does really well when working with another mental health professional because a lot of people say it's kind of chicken versus egg, right? Like, do you have your central nervous system and that impacts your emotions, or is it your emotions impact your central nervous system and how you respond? And really, it goes both ways all the time. I may be given something that's triggering and I'm going to have a sensory response, but as well, it's going to trigger an emotional response. So together as a team, we work on this by both ends.
That's beautiful, Brianna. And I have to let you know, fam, actually how I know Brianna is because we got to work together on a team and became besties. And so I really have you to credit, Brianna, really in the foundation of my beginning understanding of sensory processing. And I am really appreciative for you being here today. And now we're going to go into talking with Amber Young. Amber is our autistic OCD expert. And I think most of the fam is probably aware whether we're talking about autistic folks or other neurodivergent processing. So we could include ADHD, sensory processing disorder. We could also get into a discussion of what is neurodivergent. But for the purposes of today's chat, I would love, Amber, for you to share more about how sensory needs and sensory diets are such an important piece when understanding the autistic experience and the impact on daily life. So I would love to hear and have you share with the fam a little bit more about yourself.
Sure. So my name is Amber Young, and yes, diet is a really important part, but there's a lot of different sensory parts that we'll talk about today. So just to begin, I'm a licensed mental health counselor in Indiana. I specialize in evidence-based treatment for OCD, anxiety related disorders, so pretty much anything under the anxiety umbrella. And I also treat trauma and PTSD. I am a late diagnosed autistic person. I choose identity first language. You'll notice I say autistic person. I am passionate about autism advocacy and helping to amplify all of the diverse voices within the autistic community. So I like to say, like, if you've met one autistic person, you've met one autistic person, Since receiving my diagnosis, I've developed a special interest in studying like the overlap between the differences in presentation and effective treatment of OCD and anxiety related disorders, trauma, and autism. So, where does the autism come into play versus OCD versus trauma versus various different types of issues? Because that might make a difference in how we treat what's going on. And it might be one thing going on within a person, or you might have multiple. You might have all of those things going on in a person. So throughout this process, if I have a client who is neurodivergent or I suspect is neurodivergent, I'm going to be continually doing what's called a functional analysis, which is asking why. What's the reason behind the behavior? What's the reason the person is doing this? And this is important because we might choose to accommodate that behavior. We may choose to keep that behavior. Even if it's not something that people around them want them to keep doing, it may be serving a purpose and that person may choose to keep that behavior for one reason or another. And we may work on education and assimilating that behavior in the family, or we may choose to replace that behavior for one reason or another. So some of these might be stimming type of behaviors, but other things that I also like to keep in mind that can be related to sensory related things that oftentimes people don't think of, and I'm usually integrating into therapy, are factors like aphantasia, which is not being able to visualize things in the mind. And that is a very important component. Often I'll have times people will say, well, I can't visualize that. I can't imagine that. I know I can't imagine that scenario. That would be a sign of somebody who has aphantasia or somebody who has hyperphantasia. Those people may have high empathy because they can really imagine what is going on in that situation. So it's a very common myth that people who are autistic don't have empathy. In fact, many have hyperempathy. Synesthesia is something else that I'm going to be keeping in mind. Sometimes there might be crossing of the senses. You may have multiple senses going on at once. And so if I have somebody who seems deeply disturbed by something, it might be multiple senses being triggered at the same time. Or if something's pleasurable to somebody, stimming, it might be multiple senses being triggered at the same time. One example of that is I see colors when I hear music. And there are numerous celebrities who are musicians who are thought to have that as well. So there can be pleasurable experiences and there can be really uncomfortable experiences as well. Another one that's pretty common that a lot of people don't know about is called anthropomorphism or personification. This happens a lot with people with OCD, but also autism. This is essentially personification associating human characteristics and emotions to objects. A lot of times you will see this in autism and in our OCD community where people be like, I don't want to hurt that object. I don't want to do something to that object. And that could go interrupt the person's life significantly, but it could also bring comfort. And so always teasing that out. Alexithymia, identifying emotions, is another one of those that is going to really impact therapy. So I'm continually looking for that. And I would say the last thing too would be there is a high overlap with physical conditions that a lot of neurodivergent people experience. Just one off the top of my head would be like POTS, postural orthostatic tachycardia syndrome. And this can cause fainting, feeling lightheaded, generally feeling panicky. And sometimes this can be misinterpreted as panic attacks. And when somebody is having a blood draw, if you're taking that out of a person, can trigger a fainting episode. And so sometimes people will misinterpret that as blood and needle phobia. So you can see how the why is super, super important. And when you have a lot of these co-occurring issues that occur in people who are autistic, and we know there's a high overlap with people who are autistic and OCD. Not always are people both, but there is a high overlap. I'm going to be asking questions about what belongs to what.
That's excellent, Amber. And as you were talking, I was writing down a note on alexithymia because I feel like even in my conceptualization, whether it's right or wrong, in my conceptualization, I think of not just emotional cues, but some of those interoceptive cues that get confusing because it's hard to be able to gauge. And I think sometimes people think even a word like alexithymia, like, oh, that means they don't have feelings and they can't identify them. No, sometimes you may have them very intensely, but you don't know it's there until it's gone from 0 to 100. And so I think it's so important for people to understand, and just even more broadly for allistic folks, we're all going to have things that are pleasurable. We're all going to have things that we're avoidant to that challenge us, and we're going to have things that are neutral. But it's such an important part of just even understanding who we are to be able to understand, not stigmatize if we're not liking a certain sensation, and to be okay with and allow ourselves to accept that, oh, well, this, on the other hand, feels really soothing and regulatory to me. So I really appreciate you sharing, Amber, and I look forward to this conversation. Also, I should note, and this goes for everybody across the board who's going to be chatting today, folks, but as we're talking to the autistic experience or any of these relative different areas of sensory processing, we are not meaning to put anyone in a box and say, this is the case for all people. If you have tics, this is you. If you're autistic, this is you. We're not saying that across the board. And so I so appreciate you coming and speaking and just enlightening the scope of different things that can come up for folks. And also, if you're hearing Amber or any of us and you go, oh my gosh, I didn't hear my thing, does that mean something? No, it just means you didn't hear your thing. Because like Amber said, if you've met one person, you've met one person, right? We're also unique and creative and individual. And from there, we're going to move on to Dr. Lisa Conway, and she's going to be talking to us about body focused repetitive behaviors today. And so, Lisa, I would love for you to share with the fam a little bit about yourself and how you see sensory playing in.
I am also thrilled to be a part of the panel today. This is such an interesting discussion, and I will take any opportunity I can to talk about body focused repetitive behaviors. So, quick background is I'm a licensed clinical psychologist practicing outside of Chicago. I'm board certified in CBT. And so I also utilize evidence based practices for anxiety, OCD, trauma, and body focused repetitive behaviors. I think it's so important to identify what BFRBs are because I love that there's a lot of awareness around OCD. BFRBs are about the same kind of prevalence. About 2 to 5% of the population experiences these grooming behaviors that have become dysregulated. And so this could be most commonly thought of as trichotillomania or hair pulling disorder, skin picking or excoriation disorder, but it can also look like nose picking, cheek chewing, lip biting, nail and cuticle picking, jaw grinding, any of these things that are a grooming behavior that has become dysregulated and that someone has tried multiple times to stop. And it can lead to parts of functional impairment, interfering with life, medical concerns, if there are infections, if there are blood clots from standing in front of a mirror for a long time. So this is above and beyond a bad habit. And so that's unfortunately what I think a lot of BFRBs getting written off as is like, oh, if you could just stop, like just use no bite nail polishing, you should be fine. And so Amber already brought up my favorite concept, which is the functional analysis. So much of what we're going to be talking about today is around really getting curious around sensory differences and how can we use that information to inform effective treatment. So before talking about BFRBs specifically in a sensory context, I want to talk more broadly about the research that's being done because it's new and it's pioneering. And we're finding out that for a behavior that tends to show up in areas with a lot of nerve endings, that's easily accessible because if we don't always have skin, hair, nails, and teeth, we've got larger problems that we should be addressing. So we always have this stuff readily available. And what research is showing is that there is a heightened sensory sensitivity in most people with BFRBs, both to what they notice, and we'll talk about those kinds of things that they may notice, as well as intolerance of unpleasant sensations. There also appears to be some sensory regulation and processing concerns that may influence incoming stimuli. So people who will say, I kind of went into a trance, or like I fell into the mirror and I look up and I've spent 30 minutes, 4 hours, 8 hours engaged in this BFRB and didn't even notice what was happening. And so there's cool research going on, and the TLC Foundation, which is essentially the counterpoint to the International OCD Foundation or IOCDF, has started funding the Brain Precision Medicine Initiative. We are very lucky to have John Grant in our backyard at University of Chicago doing some of this work. And they are working on this research, putting it out now. And they've identified 3 subtypes of trichotillomania and hair pulling disorder using neuroimaging. One type is sensory sensitive. And so it's a highly focused behavior. So BFRBs can look highly focused. I see the thing, I'm going to get the thing, I'm going after whatever that stimulus is until it's done. Or automatic, kind of that trance-like, I don't even notice that it started. And then
I'm all of a sudden in the middle of it. Oftentimes we see a combination of it, but it's really important to do, again, the functional analysis for treatment. The more common type is low awareness. So this is something happening that someone's not really present in, tends to be more emotionally driven. And then the third one is impulsive and perfectionistic. There's actual morphological differences in the brain between these three types of pulling. So it's really cool. We're using this more and more to inform treatment. And then with regard to skin picking, there's one type that's more emotionally and reward driven, the most common type, but there's also a functional picking component. For some people, it seems to be associated with poor distress tolerance and, again, sensory sensitivity. So we have more and more research coming out. I can only hope that we'll continue to see it getting published as they're working through their data. But across the board, it's showing there are sensory regulation difficulties here. My favorite way I've heard BFRBs described is it's like the emotional thermostat. And so if we are feeling overwhelmed, too anxious, too stressed, the BFRB can be used to turn down the temperature. If we're feeling understimulated, bored, it can be used to turn it up. So here's this behavior that gets both positively reinforced. It feels good, it's satisfying, it's productive, and it's negatively reinforced. It gets rid of this yucky stuff that I don't want to have to feel. And that's what makes it this really tricky knot to untangle. And that's why we have more specialized treatments that go above and beyond what we've been able to do for BFRBs before. Then transitioning into the idea we'll talk about more with regards to treatment of what are the senses that are relevant in BFRBs is we'll talk a little bit about an acronym called SCAN. So this is sensory, cognitive, affective, or emotional, motor, and place cues. The ones that are most relevant to this conversation are the sensory and the motor ones. So for sensory, we're going to be talking to clients about what is it that you touch. So the crispy scab that you have, the kinky, wiry hair, the little part on the inside of your cheek that you've been chewing on that sticks out. We'll also talk about taste cues. So for some people who, for instance, after they pull hairs, they may rub follicles on their lips. They may get the taste of sebum or blood, chewing on scabs. For sight, this is one where people will talk about it is the whitehead that they know they can get. It is, again, the hair that's just looking not like the other ones, and it really sticks out to them, the cuticles that are uneven. Smell, if someone's been scratching at their scalp and kind of going after aberrations there, they may then smell fingertips and kind of see what that's like. And then sound, the Dr. Pimple Popper style that you get when you get a good whitehead. All of these are cues that may be showing for people. With regards to the motor of scamp, that's also kind of like restless fingers. So kind of like naturally moving hands over, going back with the tongue to that same spot in the lips or the cheeks. All of those are things that we're asking about because we want to be able to narrow in on what is the most functional way that we can work with this, both to create some barriers around engaging and being stimulated in that way, and also some substitutes, some other ways of coping, of not just saying, cut it out, but also what do you pick up instead? So I'm very excited to be here to talk about it.
Yes, we're glad to have you, Lisa. And like you said, it is very prominent, similar to the statistics 2 to 5% for OCD. And if any of you caught my water cooler chat from this past summer, Lisa was my main informant, as well as TLC Foundation and a number of wonderful resources that she helped to point me to. And so the statistic at the time, and I don't know if it's been updated since then, but 1 in 20 people deal with a BFRB, and that's a pretty high number. And so it's really important, and it's a great reason why we have Lisa here to be part of the conversation today. And then last but not least, we have Dr. Max Maisel. He is here to talk with us about a very complex spectrum and cluster of different symptoms that I think there's a lack of awareness and knowledge about just in the broader community. And I would say even within the OCD community, I've been learning so much already from Max. And so he's going to be talking about Tourettic OCD, Tourette syndrome, and just right OCD. And so Max would love to hear more about what these things mean and how sensory plays a role.
Yes, thank you so much, Nicole. And just like everybody else, I am so glad to be here and having this conversation with y'all. This is very exciting. Yeah, so I think you really nailed it. The differences between just right OCD, Tourettic OCD, and tics and Tourette syndrome, it's so nuanced that a lot of people outside of the OCD community have never even heard of some of this stuff. And even people inside, right, have a lot of misconceptions. So I am very much looking forward to hopefully clearing some of this up a little bit. So I like to see it as a spectrum where maybe OCD is one end of the spectrum and tics and Tourette syndrome on the other end. And then in the middle gray nuance part, we have just right OCD and Tourettic OCD. So I like to kind of ground us by kind of briefly going over what OCD is and then talking about tics and Tourette's, and then we'll sort of dive into the more nuanced pieces.
Yeah.
So I'm assuming that your listeners have sort of like a running idea of OCD at this point, but just basic review framework. OCD, we have these intrusive, really yucky thoughts, feelings, images that people really don't like, they really don't want, and they try very hard to resist or push them away by engaging in compulsions. Physical or mental acts, which are intended to help people feel better, but inadvertently reinforce the sticky OCD cycle in the long run. All right, so that's on one end of the spectrum. And then shifting over to the other end, we have tics and Tourette syndrome. And I'm going to use those two terms interchangeably. All Tourette syndrome really refers to is a presence of both motor and vocal tics. Some people have predominantly motor tics, some people vocal tics, and some people both. And that's what we call Tourette syndrome. It really has no bearing on severity of the disorder, treatment, or neurology. It's all the same stuff. What you can think about is a tic disorder. It's a neurological disorder, and it's characterized by sudden, often aggressive motor movements or vocalizations where people typically feel they're quite involuntary. They happen outside their control, and they're usually preceded by what we call a premonitory urge. And what a premonitory urge, it's a very specific acute sensory discomfort in the body that usually happens around where the tic manifests, but not always. It can kind of be anywhere, but it's usually in the same spot. And it builds up, and then the tic releases, and then it alleviates temporarily until it builds up again for the next tic. A premonitory urge, I mean, it's going to be so different for so many different people, but some of the common ones I hear are an itchiness, a burning, tightness, tension, tickling, just really like uncomfortable feelings. So the two biggest difference between tic disorders and OCD would be in OCD, it's more about obsessions and feelings, more broad like affect. And in tics and Tourette's, it's about a very acute, specific sensory discomfort, the premonitory urge. Also, in tics and Tourette's, the behavior tends to feel quite a bit more involuntary than compulsions in OCD. Again, not always the case, but typically that's what we see. So that's OCD and tic disorders. Now, when we think about just right OCD, that's more on the OCD side of the spectrum. So we're thinking about thoughts and feelings specifically. Typical OCD presentations usually involve anxiety, doubt, uncertainty, guilt, all the stuff that you talk all the time about in your podcast, Nicole.
Mhm.
Just right OCD, it's a very specific emotion of a feeling of unbalance or uneasiness. People feel like the world is off or their body is off, and they just need to do things over and over and over again to make that feeling go away, to kind of like even out that really debilitating, yucky, unbalanced feeling. For example, let's say somebody ties their left shoelace a little bit too tight. The right shoelace, that foot and their shoe might feel incredibly overwhelmingly off and unbalanced, and they just can't get their mind off of it until they tie, untie, until they're able to kind of wash out that yucky, unbalanced, off feeling.
Yeah.
And now if we shift to Tourettic OCD, which is really sort of a vicious combination of Tourette syndrome and OCD, usually it starts off with a premonitory urge, right? The very acute physical sensation of discomfort. And that sensation sort of like manifests as a tic-like behavior, which then OCD very quickly piggybacks on top of and adds its obsession and or uncomfortable feeling as OCD does. So let me give you an example. It can be a little bit tricky to understand. So say somebody has Tourettic OCD and they have a neck jerking tic, and I just say that they like aggressively jerk their neck to the left side. And that might start off as a really overwhelming burning feeling that begins at the very base of their spine, travels up to their neck, and then pops out as their neck jerking to the left-hand side. And let's say right after their neck jerks to the left with a tic, their OCD pops up. And they get a thought, what if your entire family dies in a car accident unless you jerk your neck to the opposite side? Right? So then you have the premonitory urge, and you have the behavior, the movement slipping out with like tics and Tourette's. But then you also have the guilt and the uncertainty and anxiety and intrusive thought of the OCD. And people can really get caught in these vicious cycles. And then I give one more brief example. Say somebody has a tic where they tap their right finger 3 times. And that might start as a muscle tension in the wrist that then like moves up to their finger and leads to the 3 tapping behaviors. Then they might be left with this overwhelming sense of unbalance, like, oh, my other hand hasn't tapped, and what am I going to do with that? And then they have to tap 3 times with their other hand. And that would be sort of an example of a combination of a Tourettic OCD and sort of a just right OCD feeling. Now, I'll say there's an infinite amount of ways that this stuff can play out when it comes to like the combination of OCD tendencies and tics and Tourette's tendencies. But hopefully, this gives sort of like a general framework of how to kind of differentiate between all of the stuff.
Yeah, I really appreciate that, Max. And also thinking about tics, one thing I think I've heard you remark on before too is it's really important for the individual person with the tic too to evaluate, is there a need for me to be able to change this tic? Or if I'm saying this incorrectly, please correct me, but I'm just trying to think about it. Like sometimes there's that value added, and sometimes it's outside people going, you need to knock that off. That
Yeah.
puts the pressure on, like, I should stop this. This happens with BFRBs as well. Certainly, this happens with STEMs. This happens across the board. I'm sure, Brianna, you see it in your practice as well. And so, to the degree, when is a tic worth working on? When is it leading to dysfunction or impairment in one's life? And when is it just a process of acceptance of this is part of who I am?
Yes, it's a great question. And I'll say if when it's like OCD specifically, we always want to treat that because OCD gets worse and it causes just inherently so much distress and dysfunction. Like, yeah, that's something we want to work on. Not the case with tics or Tourette syndrome. In fact, a good percentage of the time when I speak with a parent or a client about potentially treating their tic disorder over the phone, we usually decide that it's not necessary at the time. And the reason for that is because we really only want to work with tics if they're bugging the person that's experiencing them. If it's causing distress, emotional distress, physical distress, if they really want to change, then yeah, there's some really powerful strategic behavioral interventions that can really help. And it's really cool because people feel so empowered to work on their tics if they want to. But if the tics are bugging them, if they're okay, like letting their brain send these tic signals and they're like living life and they're having a rich, full, meaningful life and they don't really care about their tics, then yeah, we absolutely don't work on the tic. And we can certainly help educate other people about tics. And we can talk more about the family system and how to work with parents who might want their kid to work on tics, but the kid is okay ticking and how to sort of navigate that. But essentially, like if the person doesn't want to work on the tics or stop the tics, any pressure on them to not tic is going to make it worse. Right. So that's where we really focus more of accepting and living a life. And yeah, people can live a totally rich, full, meaningful life with a tic disorder. They do all the time. Not a big deal. And if they do want to work on it, if it's causing problems, there's some really cool ways to do that too.
I think for any of our specialties across the board, it's a matter of, again, looking at that function, right? And saying, because certainly we see this in BFRBs too, like is nail biting and skin picking a BFRB, and when is it worth treating? It's worth treating when and if it becomes disruptive to you. It's causing distress. You're feeling like I don't have agency around this and I want to. And it sounds like that would be the same with tic disorders, if I'm hearing you right.
Yeah, that's exactly the case. Nailed it.
Okay, well, this is fantastic. And I know we've talked a little bit real broadly about all of these different scopes that we're going to be just referencing in our conversations. But before we move fully into conversation mode, I just wanted to provide an opportunity if anybody wanted to talk a little bit more about the specific treatment approaches that we use respective to these different fields of study. Would love to just provide an opportunity for anybody that would want to expand on that part of the conversation.
I'm happy to talk a little bit more about treatment for BFRBs.
Sure.
So what people may have been exposed to before was called habit reversal training. So it's essentially noticing urges to engage in a BFRB or noticing that you're already in it and then doing a competing response that's incompatible with the BFRB. So you can think like lightly closing your hands and like setting them in your lap. You can't be picking at your skin or pulling at your hair if you have your hands like that. And it works, right? That's why it's stuck around. And also the more recent development of the comprehensive behavioral model, you may hear it described as COLM or COLB, is what gives us the functional analysis that comes from the SCAMP acronym. Again, not just your nail biting is an anxious habit. That just gets at the affective component of SCAMP. We are also looking for those sensory, cognitive, motor, and place cues too. And then developing not just barriers to engaging in them, like lower lighting in the bathroom, if you have some visual triggers when you're getting ready in the morning, or using bandages or the little finger cots as you're like typing emails, because that's a place you tend to do. The picking is when you're like sitting in front of your desk. It's also finding substitutes, different ways of coping. as well. So how do we help you regulate the low hanging fruit of like basic care and feeding of the person around diet and rest and movement and sleep and connection?
Mhm.
A cool, more recent development that Marla Diebler and Nate Renardi came out with is the integrative behavioral model, which brings in HRT, CALM, ACT, motivational interviewing, and some DBT skills. So it really helps to give a more comprehensive package where, again, we aren't just seeing a bad habit. We aren't just seeing an anxious behavior. We're looking at the whole person. And I love what you're saying earlier with Max about what do you want this to look like at the end of treatment?
Mhm.
So it's never the promise that this will go away altogether because you're, again, always going to have these triggers of skin, hair, nails. And yet, how do we increase a sense of agency? How do we get you back into the life that you want to be in? And that's my goal. That's where we're headed towards versus trying to kind of like shake my finger at someone and tell them where they're supposed to be. It's really exploring the values around this really hard work and using this functional analysis to get them there.
Well, and as for any of us, often that goal isn't static, right? So it can change and morph over time. And so it's a part of that process of communicating and really letting the person lead you instead of just going, well, this is what my goal for you or what mom's goal for you is, right?
Absolutely. We're a team, right? I bring an expertise on treatment, you bring an expertise on you. Let's use that together to get you into the life that you want to be in.
Yeah, and that was quite the alphabet soup too you had there. You were like, "We have this, and this." I was like, "Yes, yes." So
And I probably said it really fast.
no, you're
It's
fine.
good.
So HRT, habit reversal training, and COMB, that comprehensive model, and all of those different pieces, and so we see how the research is evolving. Brianna, would love to hear too from you because I know that you're more on the medical side in terms of how things are conceptualized, and so would love to hear about some of the research that you utilize as well in informing sensory integration, sensory processing, all of that.
So I'm going to start with how we do our assessments. And when we first interview a client, right? Depending on the age of the client, I may be also doing an assessment on the entire family. If the person comes in as a child, it's going to look a little different. I may use a sensory processing measure or sensory profile, which is a standardized tool assessment that you give to the caregiver, you may give the teacher, you may give to the music school, the bus driver, and it looks at how this child's sensory system is responding in those different environments. And those tools are catered to what we expect to look like on a school bus, for example, versus a classroom. As the child gets older, I may have the child fill out a sensory profile on themselves as well as the family, because the adolescent will really know themselves a lot more and can give us more information and contribute to that conversation in deeper ways, because usually they're more cognitively aware of what's going on and can verbalize their feelings and their thoughts about their sensory system. As we go into adulthood, if they have a partner, it will probably be the partner analyzing themselves as well as the person, the actual client, because those two could be having conflicting sensory systems. Like we said earlier, everyone has a central nervous system, and we all respond in different ways to our sensory cues based on our emotional regulation at the time. Right. So if the client comes in and they're just always upset and they don't like to be touched, and then the partner see that person's upset and their go-to mechanism is like, well, I feel dysregulated to see you upset. So I want deep pressure. So I'm going in for a deep hug on you. And the other person doesn't want to be touched. We have a big conflict and it's getting even harder to get either party regulated, right?
Mhm.
So working with both people is very important. We're also going to do a lot of the functional analysis as well. I tend to look first at the medical piece. So can we make sure we're screening out? Do I need referrals? We're doing constant nose picking and it's becoming more of what could be more impulsive and they need to do it and they're seeking it. But we want to rule out first, I may ask for an ENT referral, ear, nose, throat doctor, to make sure that we don't have just chronic allergies, or maybe we have a deviated septum. So there's a sensation that we're always stuffed or there's always something there, right? A lot of what we know with the BFRBs is these people, like Lisa was saying, they're starting to understand a little bit more of their brain patterns, and there's different sensory systems and how they fall into kind of different categories, if you will. But we also know that collectively they have more interoception. Everything is registered more intensely. And it's this eighth sense. In occupational therapy, we recognize the five senses, but there is two additional ones we call vestibular and proprioceptive input that also influence a lot of what we do and how we respond. But more discussion is happening about this interoception. And it's been around forever, of course, because it's been part of our systems. But it's just now that you're starting to hear it labeled and be more a part of the discussion. And it's still new on how to figure out how we really address interoception. But these people may have more sensitivity. So, do we have a medical cause that is contributing to these behaviors that we need to rule out? I tend to think there's a strong connection between gut and brain as well. So, if we're having other issues, we need to consult a GI just to make sure there's something there. And maybe once we get that handled, we could start working on the other piece because sometimes there's a medical cause that then created more of this behavioral standpoint after, right? So I want to look at both. And so that's kind of how we look at it. And we're also going to look at when we talk about functional analysis and looking at what's also important to the person and what they want to engage in. If I'm working with an adult, and maybe activities that they used to participate in that felt like it fulfilled their life and they feel like they can't participate in those, how do we get back to those activities? Or how do we pivot and analyze those activities and what did you really enjoy about them? Maybe we don't want to do dancing again, but what part of dance did you really like that we can find a new activity in that can help you find that regulation piece? The OT, we talk a lot about regulation, and Lisa kind of talked about it too, about getting to that thermostat and staying in that optimal temperature zone, if you will.
Yeah.
That way you can live longer and longer in that just right level. So we're going to use that sensory input to either get us to that optimal range. And then sometimes if we get too much of that input, it floods us over into the hot zone, right? So we could go from cold to hot real quick. But we need to find a way to stay in that optimal zone a little bit longer so we can tolerate and use the skills that we have to be able to participate in any activity that we want, right? Because that's at the end of it, all of us are hoping to help people just live their lives.
Yeah.
Right. So that's a little about how an OT is using it and framing it. Yeah.
Yeah, I am thinking of a client where I'm thinking going blue to red. Here we go from the cold to the hot zone. But I screw everything up because I then pair it with the emotions. And I'm like, what does it look like to be upset and green?
That's what we need to do. We don't live just in one side or the other. It has to. Every sensory response will elicit an emotion, right? And every emotion will elicit a sensory response because we're connected that way. That's how we're all wired.
I'm glad you validated that for me. I'm going to hold on to that. And we're going to get into this more because as you can hear in the language in OT, just right is a very good thing, right? We want to feel regulated. When we think about wanting to feel regulated, whether we're autistic or allistic, that's super important. We can see how just right can become intrusive when it comes to OCD because OCD likes to hijack all these value-driven things and make it very distressing. And so when we look at the function, if it's serving us, if it's bringing joy to our life or bringing industry, bringing regulation to us, that is a different thing than when we're feeling distress. And that's the piece you were talking to as well, Max, when you were talking about the tics, right? Because it's so important to know how that is serving you and also understanding our nervous system better because that is a huge piece of it as well.
With OCD, we really want to work on all compulsive behaviors, all obsessions, kind of dampen all the fire to overall decrease the activation of that flight or fight response. But treatment for tics is a little bit different. Where typically we work on the tics that are bugging people. And if there are remaining tics that aren't, then they could sort of let them be. And the cool thing about treatment for tics, not to throw out more alphabet soup, but the big acronym is CBIT, which is Comprehensive Behavioral Intervention for Tics. HRT, habit reversal therapy, just like with BFRBs, it's a huge component of CBIT for tics. We're increasing awareness. We're helping people connect the language part of their brain with the somatic kind of tic movements. And then we're having them do alternate behaviors, sort of ride the wave of those premonitory urge and sort of teach their brain to send fewer and less intense urges down the road. And once people learn those skills and understand how their tics work and how to walk themselves through a good solid CBIT treatment, if a tic develops down the road that they don't like, they can be their own tic coach. They'll know what to do. They'll know how to do it. And if there's tics that they don't mind, then they leave them be and live their life, which I think it is a really empowering kind of functional, cool way to look at things.
Yeah, and I really appreciate you sharing about that. And I think, yeah, it's such an important distinction because, again, a lot of these things, we have our normal sensory diets where we're going to have aversions to things. We're going to feel neutral to certain things. We're going to feel great about other things. And we can see how, especially within whether we're looking tics or stems or we're looking at BFRBs, we can see how a lot of different input isn't functioning in a distressing way. It's actually quite the opposite. It can be really regulatory, it can be really just accepting, which is huge. When you can accept a piece of yourself that you were confused about before, like that is probably the most freeing thing that you can experience. And so it's really only when we're looking at OCD or we're looking at this point where, oh gosh, I feel this complex frustration or shame around my tic or my BFRB or my sensory input that maybe is really clashing with somebody else in my family, that it becomes all the more problematic. And, OCD is very different than what we see with tics and BFRBs and for autistic folks, et cetera, right?
Nicole, you brought up the idea of acceptance,
Yeah.
right? Like BFRBs come along with a lot of shame oftentimes. So if I remember correctly, the numbers on OCD, it takes an average of 12 to 17 years to get accurate diagnosis and treatment. We don't have those number on BFRBs. But when I see people, sometimes still even going on for a few months, usually it's decades. So these are the discovery calls that usually end in tears because they've never talked to someone about the extent of the BFRB or what it looks like, the topography of it, especially if it involves like scab chewing or really intensive skin damage. And yet, if we can get to the space of psychoeducation and normalizing it as 1 in 20, and also start helping people get curious about how this shows up and why this shows up.
Yeah.
I'll talk about like be a Nicoleologist, right? Like we're going in there with this more curious mindset because if we're curious, we aren't scared, right? So now we can start thinking about how does this function for me? What are the elements of treatment that can help for me? And where are those lines of here's where I, again, want to head with those values driven goals. So I still want to engage in some grooming, not outsource all of it and feel a greater sense of management over it. But I think everyone here is so on the same beautiful page about helping clients develop that sense of agency and awareness. So again, they can be in the life that they be in.
Yeah, which really makes me think for our autistic population. And Amber, I want to check in with you here. I'm even thinking I've been pretty open with the fam that we have a very neurodivergent family and all three of my kids are autistic. My daughter also has ADHD. She can engage in different BFRBs and it doesn't bother her. It might bother other people sometimes, but it doesn't bother her. But we also notice when she's feeling more dysregulated, and particularly she does take medication for her ADHD just to help her focus and reduce some impulsivity for safety's sake. But part of what I notice too is sometimes she's more likely to engage in some of the picking behaviors when she's unmedicated because she's going to have a different sense of regulation. And so I wanted to check in too with you, Amber, in terms of for our autistic community and just thinking about how those different sensory systems can change over time and also how really facing allistic norms in general, some stigma in terms of how sensory processing should look, which is silly in the sense that it's so individualized. And yet there is this I feel it even as a mom, there's this bias in terms of how you should be regulating yourself and what is quote unquote acceptable. And so I would love to check in with you too, especially when we're thinking about research, because I know there's been a complex history around research with a number of different diverse populations, but particularly for autistic folks too. Would love to hear your thoughts on all of that.
Yeah. So just listening to everything that everybody's been saying, lots of interesting points to kind of piggyback on. You were talking about, Lisa, the shame and probably like underdiagnosis and misdiagnosis. And that is definitely prevalent in the autistic community. And Nicole, you were talking about the research. We are in a renaissance when it comes to the autistic community. A lot of research is being done in the UK right now by autistic researchers themselves. And what they're finding is that there is a significant portion of people that have been Typically, they might be the presentation that the research wasn't based on. A lot of the research was based on kind of young little boys who were white and this kind of stereotypical model. So if you were anything that was outside of that box, you may have gotten missed. The recent research has said that, the standard was estimated that about for every 4 men diagnosed, there was 1 woman. They believe that it's actually for every 3 men, there are 4 women out there who are autistic. So it's actually probably the reverse. There are probably more autistic women out there who are not diagnosed than we realize. And so that's why you may be seeing like a surge of people saying like, hey, I think I'm autistic, or I just got diagnosed autistic and I'm an adult. And you're going, wait, what? Like, is this trendy? No, it's not trendy. There's a lot of people who got missed. About 80% of females remain undiagnosed at age 18. And that has a huge impact. Imagine having a health condition and not getting treatment for it your entire life, or just thinking that you were different in so many different ways and not really understanding why. So it has a huge impact on people. Now, in terms of sensory things, talking about a renaissance, in the past, we had a lot of different treatments that we would talk about. We would talk about ABA, we would talk about things like that. The autistic community has pushed back about that in droves. And the reason why is they have said that it has really encouraged masking. It has encouraged a lot of, kind of like we've been talking about agency and like, do I want to continue this behavior? Is this harmful? Is this stemming? Is this regulatory? Is this a harmful thing? And so for that reason, there have been a lot of advocates who are autistic who have come out and said like, hey, I don't know that I feel comfortable with this. So what I will say is there is not one type of treatment per se that is recommended. We are still in our renaissance right now. But what I will say is that a lot of things are emerging in terms of neuro-affirming therapists. And a lot of us are recommending a few things. Spoon theory gets talked about a lot, or something to that extent, in terms of like, how much resources do you have and what can you give, and communicating that with people around you. Discussing autistic burnout and what that is and the consequences of that. And masking. Now, not everybody has the privilege or ability to unmask. If somebody is in a situation where it might be dangerous to unmask, that's an issue. Also, if somebody is very late diagnosed, they've been masking their entire life and the mask might be part of them. And so we discuss, what parts of yourself can you pull forward? What parts of yourself can you let step back?
Yeah, that's a really great point. And something too I like to highlight, whether I'm working with my clients or just people in my life, because there are people in my life and in my community and my own family dealing with different attributes of all these things. And I think the cultural piece is so important to consider too, because we look at different cultures, whether we're looking at different neurotypes, whether we're looking at different ethnic cultures, Western versus more Eastern cultures, we look at how communication, how problem solving, how even something like respect your elders can get personified. And so when we start to see different sensory seeking, neutral, or avoidant behaviors, let alone different escalations of, say, a BFRB or a tic where there is more distress, certainly with OCD where there is more distress, certainly if we have masking and autistic burnout or there is more distress, that becomes a very challenging thing to address across different cultures, because we all have our own individual family culture. But then also we want to consider how having this conversation, even reaching out to a healthcare professional, whether it's mental health or even a doctor, can feel very, for lack of a better word, dysregulating to reach out, because is this something we do culturally? Is this something we accept as a problem? Is this a reflection of me as a parent that my child may do this or that? And so would love to hear you guys' thoughts on the cultural piece.
That's a great question. Oh man, right. We are learning more and more about BFRBs, which is cool. And yet there is a real paucity of research in the area, and seeing and getting curious about, especially culturally, people, like you said, like seeking out mental health treatment, or with different valuing of cultural and ethnic backgrounds, different gender presentations on hair, on skin, on appearance, right? All of this gets more complex. There could be more barriers to getting into care, more stigma around it. And yet it's looking at the assessment of it, like hopefully we continue to spread the word about like this isn't just a bad habit with
Right.
BFRBs, right? There are treatment options and it's not this like directive, you must stop doing this thing, especially this thing that you like, right? Or that has served you so well. It's instead like, how do we minimize the impact of it on you? How do we get you more readily into the life you want to be in? Which includes being in your cultural environment, your family environment, your daily environment, your school versus work versus home environment. So it remains a large topic in which we need more research. Every time TLC Foundation says we should do more about cultural stuff, and be like, yes, please put more people at the table. And then it's a work in progress.
Yes. Yeah. And I'll recognize that from appearances, at least appear white. And I would love more representation too on that. And I think it's an important continued piece of the conversation because there is limited research. And then even, and I know in these conversations, in terms of even BIPOC clinicians having support and being leaders at the table, not because they're BIPOC, but inclusive of being BIPOC, because they're experts, because they're knowledgeable, because they have a lot to contribute. And so I think it is a huge piece too that we have to consider. I know here in the Midwest, and I wonder, it might be a little different in Chicagoland area where you are, Lisa, and Amber is at least near a bigger city in Indiana, but people are more, especially something like ADHD, for example, 1,000% more likely to turn to essential oils, vision therapy, or go to maybe even OT than they are to come to, say, a mental health therapist and say, hey, we suspect ADHD here. And so it can be challenging because, again, I think that's a piece of the cultural stigma. It's okay for me to go to a medical doctor. It's okay for me to go to somebody with doctor in the title, but therapist, I'm not crazy. I don't want people to think my kid is crazy. It can get really complicated.
We've done a really poor job in the medical and mental health field in terms of our treatment of people who are minorities. A lot of harm has been done. It's understandable that a lot of people are leery and are nervous about it. Also, some of our criteria in terms of diagnoses, when we look at them objectively, I know that there's kind of like the not otherwise by culture in the DSM, but some of the criteria is a bit exclusive in terms of some cultures do things a little bit different. So it can seem a bit exclusionary for some cultures. In terms of autism specifically and sensory differences, I'll be flat out honest, it can be dangerous to stim in public if you're a minority in certain places. People have been hurt and unalived. That has happened because it's been mistaken as being violent when they were just stimming, moving their bodies to get energy out. There is a privilege that comes along with having a certain color of skin, and not having a certain color of skin does put you at greater risk for injury and death. And if you are neurodivergent, it puts you at even greater risk for victimization. That is a serious thing that we need to acknowledge as mental health professionals and professionals in the health field.
That's a great point. I would imagine too for tics, Max, because people interpret behavior through their own lens and then they kind of project that meaning onto it. And based on how you're perceiving the meaning, then your reaction to other people, as you're saying, Amber, can create these unsafe scenarios when really it's a very innocent manifestation of someone's braining.
Yeah. So the treatment itself, again, for like tic management, it's very technical and very behavioral, but what's not very technical and very behavioral, and one of the most important parts of like CBIT, comprehensive behavioral intervention for tics, is the socio-emotional cultural component. And that's really kind of having a conversation with people about, well, what's it like with you, your religion, your skin color, your gender identity, sexual orientation, all the different kind of like parts of you. What's it like walking around in a world of tics, right? And how does that play out? And I mean, there's so much nuance and richness there. And if you just focus on getting through the CBIT treatment manual, you miss out on this like really incredibly important stuff. So yeah, it plays a major role. And Nicole, I'm really glad that you brought up, I think cultural context is always so important and not always talked about as much as it should be. So it's really important to
Yeah.
put that open.
Yeah, well, OCD doesn't discriminate. Tics, brain neurology doesn't discriminate. We're born how we're born, right? But at the same time, our world does. Our
Yep.
world does discriminate. And so part of creating justice-based and liberation-oriented treatment and neurodivergent affirming care is to say, like, we got to recognize there are real barriers here. And what can we do to address some of those barriers? And some of that experience might come with working with an interdisciplinary treatment team. Because even between, I would say, medicine and mental health, ideally, I'm always psyched when I get to have these collaborations. I used to work with Briana. I loved our coaching. I loved our consultations. I've learned so much. And so I think it can be a great thing. But sometimes we have medical people positioned against other people. And we also have this persona amongst some experts in the field that I really am better than you and I know more than you, and you are a notch on my belt and you are my 15-minute time window or whatever the case may be. And people feel the impact of that. But really, we are all the experts in our own selves. And as parents, we're the experts in our children, especially when they can't vocalize that for themselves. And so we need to be treated as experts in that. But it can be difficult because sometimes medical people, and I know I've talked to doctors as a therapist where they're like, "That's cute, you and your mental health stuff." And vice versa. Sometimes mental health therapists can be real patronizing to doctors, and that's not helpful either. And so part of looking at your team is even if you're like, "Man, this person is rated so well, they're top notch in their field," if they're not able to listen to you, that is a big old red flag because you need a team. And in a team, we communicate and we don't put each other down and we contribute. We all contribute. And parents are huge on that. Family members, you're huge on that. Lived experience warriors, you're huge on that. If you don't have a seat at the table, let alone like a head, because it's you, problem. Big problem.
There was someone in one of my consult groups for BFRBs, Jen Patterson had this, and I know it kind of crossed the thing is like nothing about us without us.
Yes.
And so knowing some of my colleagues who are on social media and active, like Sahara Dixon with Amani BFRB and Jason Yu with Fidget, like people of color with a lived experience, spreading information, getting the idea out there of what treatment can look like, this top down, bottom up of like, where's the research coming from? Who's helping inform the treatment? Right. May we all continue to, like Amber was saying, this research coming out that's being done by people who are autistic. Like, let's be informed and have greater, more open conversations versus this more like siloed, white coated, doesn't feel good, lousy situation.
Absolutely. And even within the autistic community, we have to be careful that, like you said, if you've met one autistic person, you've met one autistic person. Sometimes some of us that are lower support needs, because we've gotten overlooked, because we got our diagnoses really late in life and we're misunderstood, we want to spread awareness about that. But at the same time, we have to be careful that we are also out there spreading awareness and advocating for people with high support needs. And we're amplifying their message. We're not actually speaking for them. We're amplifying their message. We're taking their experience and amplifying it if they're able to, if they are verbal. If they're nonverbal, we're helping them find ways to communicate their experience and those kinds of things. So
Yeah.
very, very important.
Well, and to that end, a lot of people that are nonverbal in terms of spoken language are still able to communicate, whether they're using specialized devices or whether they're even using gestures and whatnot. And so valuing that they get to contribute. If they are indicating discomfort with something, we don't need to be like, stuff it. You need to do this. You need to respond to my treatment goal. I know better than you or a parent. Like, no, we need to respect, like, this is really dysregulating for them. What do they need? How can we help people self-advocate? And that goes for autistic or not, but I think it is really important because we think of this in children. And I know Briana and I have a background in infant mental health, and this is a huge piece, right? Because, an infant isn't just going to sit up and tell you, but an infant is communicating a lot through its attachment, through its responses, through how it's reacting and the bond it's being able to create with the caregiver, with other people. And so we have to also credit communication isn't just verbal or spoken word. It can be utterances. And I know that you weren't saying that, Amber, but I just wanted to add that point especially for any parents listening that are like, my child still can't speak, but maybe they are able to talk through, what are they called? The iPad devices.
Like an augmentative communication device.
Yes, yes,
Yes. Yeah.
that's
Yeah.
exactly it.
Or even the PEC system or something. Yeah.
Yes, PEC system even. I mean, it's the thing too for anybody who's ever had a kiddo with a speech delay. It becomes a real challenge, right? Because if you can't communicate your world, you get more frustrated, you're upset. Well, that makes sense because your brain is continuing to develop. Just because you have limited access points of how to help facilitate what you're feeling doesn't mean that your brain is just only thinking those three things or whatever the case may be. And so that leads to a lot of frustration and a lot of meltdowns and a lot of these different things that get pathologized when really it's like, hey, if I'm not understood, no matter how much language I have a meltdown too. I'm upset. Like, I'm feeling hurt. Excuse me?
And it may have absolutely nothing to do with their cognitive ability.
Absolutely. Yeah.
A lot of times people will be like, oh, they there's nothing cognitive. They have a cognitive deficit. And that's actually not necessarily true.
Yeah. I hear this a lot. Again, my frame of reference with my kids, but people will be like, but they're good. They're smart. I'm like, it's not a matter of smart, but if we do just even zoom out and look at the intelligence scale, what does that mean for people that have different deficits in other areas? That's not validating to people of all different abilities. Yeah, I could
Just,
get on a soapbox.
just differences, right?
Yeah.
Just put together differently.
Exactly. Oh gosh. Well, shall we pick up from Q&A next week?
Don't threaten me with a good time.
So good. You guys, this was fantastic, and I will see you again soon.
Thank you.
Thank you.
Absolutely. Bye, guys.
See you guys. Thank y'all.
Thank you for that.
Fam! Holy moly. What a great time of chatting, learning, collaborating on all things sensory. Isn't it interesting how many of these scopes can overlap and yet bring such different treatments and interventions to the table? It's fascinating, right? But I think function was the name of the game today because if we weren't being curious about function, then we were missing some pretty big, pretty important data. And that brings me to today's intrusive thought segment, which for any new fam is my application segment of the show. It's where we take all of what we just heard, all of what we just learned, and we think, how can I make sense of this today? So for this week, I want you to think about your sensory systems, and I want you to zoom into what and how their function provide a really special roadmap for you. This is not to shame. This is not to blame. This is for us all to be curious and learn a little bit more about ourselves. For example, shortly before publishing today's episode, I was sitting in car line, ready to pick up my kiddos from school. Where are my car line parents at? Woot. And though it's been a little overcast today, it's also bright and has had intermittent peaks of direct sunlight that blast my face off from time to time. So as I was in car line, I thought about, man, the sunlight, as much as I enjoy basking in it and soaking in that vitamin D when it graces our presence, it really kind of hurts. And why? Why? Because when it's bright, I squint. And then when I squint on a day like today, where I'm acutely aware that I have a headache, well then that makes my headache hurt more. Just like holding my jaw a certain way doesn't feel good when I have a headache. And so after following this ripple effect out a ways, I wondered if maybe just putting on a pair of sunglasses from my purse might help. And you know what? It did. And that might sound like a ridiculously simple solution. But hear me out. It was overcast, and it wasn't my first thought to just grab some sunglasses. It wasn't even, quote unquote, that bright at the moment. In fact, my first thought, or really just my modus operandi, is probably to just grin and bear it when it comes to things like that. Car line doesn't take that long, and if it's still bothering me when I get home, I can take some headache medicine. But actually acknowledging the function of all these different sensory experiences that we're compounding and allowing myself to just be curious and wonder, hey, could sunglasses help in this situation? It actually helped so much. Sensory stimuli, how we're receiving it, how we're experiencing it, it makes such a difference. And while it likely won't solve my headache at the end of the day, it does lead me to a better quality experience and better learning about myself. So I want you to think through today. tonight, wherever you are, whenever you're listening to this. Are you driving for your commute? What sensory stimuli are you seeking or avoiding? Are you washing dishes or folding laundry? Because if you are, please first tell me how you engage your sensory system to want to fold. I need help. It's a problem. It really is. Oh, I hate folding laundry. Think about, what am I doing? How is this functioning to serve me? Or is it even serving me? Is it working against me? Am I just in a mode of grin and bear it? And do I have to be? If you are drifting off to sleep or exercising, what is this input doing for you? If that deep hug or that need to have nobody touch you, leave you alone, if that resonated with you, I encourage you to be curious as to why. And then, family, I want you to come back and join us next week, because there's so much more that we can and will discuss. And because, fam, you're important. We are important. And we are better together. Thank you for joining me and our OCD family community. If you enjoyed what you heard today, please like and subscribe to the OCD Family Podcast wherever you enjoy your podcasts. Did you find this content helpful? Please consider leaving a review. The more people that know they're not alone, the better. For more information regarding today's podcast, please visit ocdfamilypodcast.com and remember to join the email list while you're there. It will provide you with the most up-to-date information, resources, and the down low on the family chatter. Oh yeah, nothing says family like talking with sensory friends and learning till the end. That's right, I went there. And you can too at OCD Family Podcast.